Okay, we are going to look at a practical approach to hyponatremia. Majority of the ICU deaths are due to electrolyte imbalance. Very unrecognized. People think infection, respiratory failure, cardiac failure, heart attack are the causes of ICU deaths. They are no doubt. But this electrolyte abnormality is outnumbered. That's why very close monitoring of the electrolytes is indicated. Just look at this chart. We have total body water. Let's say a person is weighing around 60 kilos. And body water is 35 liters. That is around 55% of the body water in men and 50% in women is water. Total weight 60, women 30 kilos water, men 35 kilos water. Why? Why it is so? We came from the sea. All of us are evolved from the sea. We carried that water, that salt water, that saline inside our body. All tissue fluids are saltish because we have evolved from the species, fishes, amphibians, like that. Okay, why women hold less water compared to men? Because the fat doesn't hold more water. Fat is not soluble to the water, no. So your water content is comparatively less compared to him. That you have to keep. Why? I have to calculate in the end depending on the gender. So look at the distribution of the electrolytes. Extracellular fluid, intracellular fluid, intravascular fluid. There are three compartments. Intravascular within the blood vessel, intracellular within the cell, extracellular or interstitial between the ICF and the intravascular. This extracellular fluid, the most important ingredient is sodium, potassium to small extent, and then magnesium in this chloride. Sodium and chloride are the dominant ions in the extracellular fluid. In the intracellular fluid, potassium and magnesium, bicarbonate are the dominant ions intracellular. This is the difference. And the cell membrane is the semi-permeable membrane which restricts the movement of sodium and chloride in and out by gating channels. Okay, so simply intracellular, potassium, magnesium, bicarbonate, phosphate. Phosphate mainly, phosphate and little bit of bicarbonate. When it is outside, it is sodium and chloride, small amount of the other. So you need to know what is called osmolality. There are two terms called the osmolarity and osmolality. So when you use R, it is the weight. When you use the L, it is the liters, the denominator. LR, that's the only difference. So what is important for us is we are interested in the osmolality of the plasma. How do I calculate the osmolarity of the plasma? What is the normal serum osmolality? It is around 280 to 290. It's a very tight, narrow range. 280 to 290, it is maintained. What is the formula? 2 into sodium plus potassium plus glucose divided by 18 and 1 divided by 2.8. Let us say the individual serum sodium is 132, potassium is 4, 132 plus 4 is 136, multiplied by 2 is equal to 272, plus 108 by 18, let's say glucose is 18, and divided by 18, and that is 6, and 1 divided by 2.8. 1, let's say 14, divided by 2.8 is 5. Where do you want to divide glucose and 1? You are not friendly with them. You are not dividing sodium potassium, you are dividing glucose fellow and 1. What is this partiality? Why? Sodium and potassium are expressed in milli-equivalent. Glucose and 1 are expressed in milligrams. You can't combine milligrams with milli-equivalent, isn't it? So you have to convert them into milli-equivalent. So the milli-equivalent is divided by the equivalent. Milligram divided by equivalent weight is milli-equivalent. So glucose divided by 18 will become milli-equivalent. That is why 1 divided by 2.8, its equivalent weight becomes this. So I've taken numbers which are convenient to divide. 108 by 18 is 6. 14 divided by 2.8 is 5. So now you add them up. So 272 plus 6, 278 plus 5, 280. Or 272 plus 11, which is 280. Now I'll give you one sum. You do that. You have a pen and even there also. A person's sodium is 129, potassium is 5, glucose is 126, one is 16.8. I am repeating. Sodium is 129, potassium is 5, glucose is 126, and then 1 is 16.8. Calculate the plasma osmolarity. Calculate the plasma. You can also do that. Take a paper and tell the values to you. You see your calculation. How much you got? I've already finished calculating in my mind. Correct. How do you do? 129 plus 5 is equal to 134 into 2, 268, and 126 by 18 is 7. I have given 128 because it is easy for you to divide. While giving itself the sum, I added 18 to the 108 and gave you. That is 7. And 14 I added 2.8, that is 16.8 divided by 2.8 is 6. 6 plus 7 is 13. Original number was 268 plus 13 is equal to 280. The normal range is between 280 to 290. This is the plasma osmolarity. You must know how to calculate the osmolarity. What are the things you require? Automatically require sodium, potassium, you require glucose, and you require carbon. And there is what is called the plasma osmolarity by the lab. Lab, you send the specimen, they will directly give the osmolarity, the osmometer, without going through this formula. This is called calculated osmolarity. That is called observed osmolarity. The gap between them is called the osmolar gap. What is osmolar gap? The observed osmolarity minus the lab osmolarity is called the osmolar gap. I require to know it at some point. That's why I am telling. Okay? Now, sodium is what is the one which is contributing to that? Sodium is the safe cation. If you are multiplying 131 by 2, out of 280, 262 is already sodium itself. So the dominant player is sodium. The other dominant player could be hyperglycemia or hyperburn. I increase your blood urine nitrogen can also increase. Potassium being a small contributor is not going to really alter the osmolarity. Some formula. Even omit potassium will get for ease. Because potassium measurement is a little tricky in all the labs. Okay. Anyway, that is the formula. 140 milliequivalents per liter ECF versus 25 milliequivalents intracellular. Extracellular 145, intracellular it is 25. Okay, total body sodium is more than 5000 milliequivalent. 85 to 90% is in the extracellular fluid. Only a small proportion, 15% is in the intracellular. It is responsible for 90% of the osmolarity is due to the sodium. That is why sodium movements are very much affecting the movement of the osmolarity. That is why hyponatremia is so important. The sodium is important to maintain the blood pressure and also the volume. ECF volume and pressure. Daily requirement of sodium is 100 milli equivalents, which is equivalent to 6 grams of sodium chloride. What is your requirement? 6 grams of sodium chloride per day. Into 30 days, how much? 180. A family of 4, how much? 720. What is the salt available in the foods other than table salt? 1/3. So 500 grams of sodium only is required by a family of 4 people. They buy 2 kilos and add, consume. Where does it go? Who is sending it out? Kidney. So you are unnecessarily throwing excess salt burden. What is called tax deduction at source, TDS. By purchasing itself, don't purchase more than half packet of salt for a family of one salt packet, 4. This is the instruction. Because most of the disorders of cardiometabolic disorders are because of excess salt, hypertension, renal failures, problems. 1 gram of sodium chloride gives 117.1 milli equivalents of sodium. It is called Na because the Latin name is natrium. Natrium is the Latin name, that's why the Na. Look at that. So what is the very important regulator of the plasma osmolality? Other than the electrolytes, the important regulator hormone is the antidiuretic hormone. Antidiuretic hormone or ADH, AVP is the arginine vasopressin, synthesized and secreted by the neurohypophysis or posterior pituitary, includes the nuclei in the hypothalamus which terminate in the posterior pituitary. The nuclei are in the hypothalamus, their axons are in the posterior pituitary. They secrete the neurohypophysis and then the neurohypophysis secretes the antidiuretic hormone, also called the vasopressin. Look at that graph there. So 285 is the normal osmolality. The plasma ADH is 4 picograms per ml at 285. The moment the plasma osmolality comes down, that means plasma has become dilute. Then what will happen? When the plasma is dilute, you should excrete more water. So the antidiuretic hormone is stimulated, and then there is no antidiuretic hormone at around 280, antidiuretic hormone becomes 0. The other way around, you go to 295, the osmolarity has increased, you have to retain water, so you secrete antidiuretic hormone more. So at 295, around 12 picograms will be the rate. So what is my message here? So plasma osmolarity is a direct determinant of the ADH secretion. Normal osmolarity of 285, the ADH is around 4 picograms. If the osmolarity comes down, that means plasma is dilute, then you need to excrete more water, so there is no antidiuretic hormone. Water is diuresis is permitted. When the plasma osmolarity is higher, the plasma is concentrated, you want to retain water, so you want antidiuresis, water should not go through the kidney, water is conserved, and ADH values go up. Define what is hyponatremia. Hyponatremia is a serum sodium concentration below 135 millimoles per liter. So it is expressed as milliequivalents or millimoles per liter. 135 less than that is hyponatremia. Normally you see several times 131, 129, 130. They are all actually hyponatremia. You will not take into account. Keep in mind 135 is the lower limit. Most common disorders of electrolytes encountered in clinical practice, 22% to 30% of the hospitalized patients are electrolyte abnormalities pertaining to the sodium hyponatremia. This is an independent predictor of mortality. Acute mortality 50%, chronic mortality up to 20%. Challenge among physicians to identify the cause. Basically, hyponatremia is not giving sodium. Hyponatremia, you see a report, don't try to infuse sodium immediately. Not easy like that. It is basically water imbalance that changes the sodium balance to low sodium balance. You have to identify the cause and treat it. So what are the causes? That caveats in hyponatremia. Caveats means warnings. Acute severe hyponatremia is dangerous. Same hyponatremia 120 over a period of 3 months, not dangerous. Some fellow develops hyponatremia 125 within 2 hours, dangerous. Acute onset hyponatremia is more dangerous. Chronic hyponatremia, body is able to adjust. Okay. Rapid correction of hyponatremia should not be attempted because of central pontine myelinolysis. CPM. CPM is a dreaded complication. You give the treatment today, he will develop after 1 week. So he'll not be able to sue you also. He'll not know. You gave him excess sodium, sent him home. He develops central pontine after 10 days, then he thinks he's got some new disease. He thinks doctor has treated well, I am all right. But doctor only knows that it is due to. So don't tell them. Central pontine myelinolysis. That is to say, you have to watch patients who have treated for hyponatremia for at least 1 week to 10 days, follow them up. And some of them may develop CPM. Outcome depends upon the underlying disease. Hyponatremia outcome depends upon what is the cause of the hyponatremia. Sodium and ACF, that the sodium in the extracellular fluid, it gives the tonicity of the body. And it is not that reflection of total body sodium content. Hyponatremia can have 3 types of tonicity. That means plasma may be hypotonic and hyponatremia, normotonic and hyponatremia, hypertonic, treatment varies. Is it a normotonic hyponatremia? That is, plasma osmolality is normal, there is hyponatremia. Plasma osmolality is increased, there is hyponatremia. Plasma osmolality is depressed, then hyponatremia. So obviously you need plasma osmolality also to know whether it is low, normal or high. So how do I know the osmolality? 2 into sodium plus potassium, glucose divided by 18, bond divided by 2. That is calculated. Okay. Hyponatremia depends on the tonicity. I told you, tonicity is the plasma osmolality. Hyponatremia, isotonic hyponatremia, hypotonic hyponatremia, hypertonic hyponatremia. This brings immediately what are the various types of hyponatremia. Low sodium serum osmolality, hypotonic hyponatremia, that is less than 280 milliosmoles per kilogram. That is the hypotonic. Blood is showing hyponatremia, so the osmolality is also low. Hypotonic hyponatremia, that is called the true hyponatremia. Because not only the sodium, the volume also has come. Volume is tonicity. Volume, tonicity, and then sodium all are depressed. That is why hyponatremia, hypotonic hyponatremia. The second one is normal serum osmolality, isotonic hyponatremia. Serum osmolality is between 280 and 295, and there is hyponatremia. Means there are 2 important conditions you should remember. One is hyperlipidemia, the other is hyperprotein. Nobody thinks. Hyponatremia means they don't look at triglycerides, they don't look at the proteins. So hyperlipidemia and hyperproteinemia, as in case of gammopathies and multiple myeloma and any other protein rises, meaning immunogammopathies. Hyperlipidemia, particularly triglycerides, will increase the normal osmolality will be normal, but the hyponatremia will be there. The third one is high serum osmolality, hypertonic plasma, more than 295. There are only 2 conditions, hyperglycemia and infusion of mantle. These 4 conditions are not true hyponatremia. So immediately what I need to know, when I have a patient with hyponatremia, I must know the osmolality, I must know the triglycerides, I must know the serum proteins, I must know the sugar levels, I must know whether he has any radio contrast dyes or mannitol. Even radio contrast injections also will produce a hypertonic hyponatremia. You understood? Okay. Keep this in mind. I will ask you after some time. Then, pseudo-hyponatremia. There is a condition called pseudo-hyponatremia. Isotonic hyponatremia. The tonicity is normal, plasma osmolality is between 280 and 285, expansion of extracellular fluid with isotonic fluids without sodium. This is iatrogenic. That means somebody has given him IV fluid. Okay? And the tonicity is maintained because IV fluid, what you are giving, 5% extra is isotonic. So tonicity has not changed, but sodium is dropped because of dilution, excess of IV. Inadvertent administration IV fluids will result in dilutional hyponatremia. Yeah. Because the tonicity is maintained, the fluid is isotonic you have given, but you have not given sodium. The other way is, there is no transcellular shift of water, but the sodium decreases because of the dilution. Examples: hypertriglyceridemia, hyperparaproteinemia, as in case of multiple myeloma. It is not a disorder of the sodium, but it is dilutional hyponatremia. Correct the underlying cause, sodium treatment is not required. What do you do in that case? Suppose a fellow came with hyponatremia, isotonic, and it is dilutional hyponatremia. Is he taking excess IV? That is one. Isotonic fluid or hypertriglyceridemia, hyperproteinemia, as in case of multiple myeloma. Treat the underlying disorder, the hyponatremia automatically is correct. Hypertonic hyponatremia. What are the two causes we said? One cause is the mannitol, the other is hyperglycemia. Hyperglycemia being more common of the two, very common. Increase in effective osmoles in the extracellular. What are the osmoles? Glucose is an osmotic substance. And then the mannitol is also an osmotic substance. That is the reason we give mannitol. Mannitol is given to withdraw fluid from the brain for cerebral edema because it is hyperosmotic substance, thus causing translocational hyponatremia. Example, diabetes mellitus. How much it will shift? Hyperglycemia, plasma sodium falls by 2 milliliters for every 100 milligrams increase in glucose. Suppose 100 milligrams increase to 300 milligrams increase, 6 milliequivalents it will fall. Between 200 and 400 and beyond 400, 4 milliequivalents it will drop. So much so, whenever we have severe hyperglycemia, the hyponatremia is not really true hyponatremia, but it is due to the effective glucose being the osmotic substance. It is trying to retain fluid, and that fluid is causing a dilutional hyponatremia. Hypertonic mannitol, treat the underlying disorder. Radio contrast type, so you can add in the slide. So, now, what is the physical examination I need to do? Because you have to clinically examine the fellow. Assessment of the volume status. Volume status can be, how do you assess volume status? JVP, skin turgor, blood pressure, bounding pulse, heart rate, dry tongue, dry extremities, dry skin, sunken eyes. Okay, these tell you about the volume status. The volume is important because there is a true hyponatremia can be hypervolemic, normovolemic, and hypovolemic. First classification is hyponatremia, hypoosmotic, normoosmotic, hyperosmotic. Hyperosmotic, glucose, mannitol, radiocontin. Normoosmotic, triglycerides and paraproteins and isotonic fluid. Three causes. Hypovolemic and hypoosmotic and hyponatremia. Look at the volume. The volume may be normal, may be low, may be high. How do I assess the volume? JVP, skin, BP, heart rate, tongue, sunken eyes, knowledge. Wasting and cachexia, if the patient is having wasting and cachexia, diabetes insipidus, diabetes mellitus, malignancy are the reason. Skin manifestations are there, maybe due to cancers, dermatological manifestations, internal malignancy, and then diabetes mellitus. Nails, clubbing of the nails, CKD nails, carcinoma of the bronchus. Anemia, CKD and malignancy. If you see anemia, suspect CKD and malignancy. Lymphadenopathy, infiltrative disorders, and malignancy. Fundus examination is a must in all patients for hyponatremia to detect diabetes mellitus changes and hypertension changes and papilledema. Okay. Clinical diagnosis of hyponatremia. The symptoms are primarily neurological. Development of cerebral edema with a rigid skull, headache, lethargy, confusion, gait disorder. Nausea and vomiting, severe hyponatremia, seizures may be there, coma, brainstem herniation, permanent brain damage, or death. So mostly neurological due to cerebral edema, headache, lethargy, confusion, ataxia. Nausea and vomiting, and seizures, coma, brainstem herniation, permanent brain damage, and death can occur. So how do I classify hyponatremia? Less than 135, mild, less than 130, moderate, less than 120, severe. That means 120, less than 120, severe, 120 to 130, moderate, 130 to 135, mild, more than 130. Oh. Okay. So laboratory work, what I should ask? Plasma osmolality, sodium, and potassium. Yeah, we require to know sodium, potassium, and plasma osmolality. One is required, creatinine is required, plasma glucose is required for calculation, uric acid is required, urine sodium is required, urine potassium is required, urine osmolality, and fractional excretion of sodium. FeNA. I'll tell you what it is. Fractional excretion of sodium. Serum proteins, lipid profile are required to exclude the hyponatremia normo-osmotic. Thyroid, adrenal, and pituitary function are required. Chest X-ray, BA, CT thorax in brain for any carcinoma of the lung, carcinoma of the bronchus, and any other carcinoma at all. So these are the routine evaluations that we need to do. Now we come back to our original slide. Hypotonic hyponatremia. Now we have excluded the normotonic hyponatremia. We have excluded the hypertonic hyponatremia also. We knew the causes. We knew how to manage them, treat the underlying disorder. Now we are left with hypotonic hyponatremia, which is also called the true hyponatremia. Okay. Here there are three. One is hypovolemic, the other is normovolemic, euvolemic, the other one is hyper. How do I know? Who will tell me hypovolemic or hypervolemic? Patient will not tell. You have to find. My JVP is very much elevated. Edema is there. Patient is having tachycardia and fluid retention. Hyper. Patient has sunken eyeballs, dry skin, ready pulse, hypotension, history of diarrhea, vomiting. Hypovolemic. None of these things are there. No. Okay. So clinical examination is must to decide the hypo. Now we will go to the euvolemic hyponatremia. That means what? Who is this fellow? He has got serum sodium less than 135. His osmolality is lower, as hypotonic fellow, and his volume is normal, and that fellow we are looking. Hypotonic hyponatremia with normal ECF volume. This is called syndrome of inappropriate antidiuretic. Rarely hypothyroidism, adrenal insufficiency. Under euvolemic hyponatremia, only three categories are there. SIA, syndrome of inappropriate antidiuretic. What is the presentation? He will have hyponatremia, he will have normotonicity, and he will have euvolemia. Then endocrine deficiencies like hypothyroidism and adrenal also can be there. A word about the CM. We require to know that ADH is inappropriately elevated in CM. That is why it is called inappropriate antidiuretic. The name itself is inappropriate ADH. What is the appropriate ADH? You have seen, depending on the toxicity, the ADH should be there. If it is 285, it should be 4. If it is 295, it should be 12. If it is 275, it should be 0. That is the appropriate. That happens. Body is not recognizing the tonicity and producing ADH. ADH is just coming just like that. Means what? This is not under the control of the normal baroreceptor. And something else in the body is secreting the excess ADH. Unregulated ADH secretion by a tumor or from hypothermia. ADH increase in basal state in response to hypertonicity, reset osmostat, activating mutation of the V2 receptors, permitting the reabsorption of water in the absence of ADH, natriuresis in the so forth. Increased atrial natriuretic. These are some of the features of antidiuretic inappropriate harm. Now, what are the diagnostic criteria? When I diagnose here, certainly this will be a not short. Here, the alternate examination, here is asked. You should know about it. What will be the plasma serum concentration? It should be hyponatremia, so less than 135. What should be the osmolality? Osmolality should be less than 280 because the hypotonic situation. And urine osmolality is increased more than 100 because kidney is not at fault. Urine sodium concentration is also more than 20 milliequivalents. Patient is clinically euvolemic, no features of adrenal or thyroid. Why? Because those two conditions also can produce similarly. If you want to establish here, you must establish adrenal function, normal, and then thyroid function. And also look at the urine. Urine osmolality should be there. Urine should not be dilute, and urine sodium concentration so is maintained. That is to exclude the renal disease. Okay. Now, syndrome of inappropriate antidiuretic hormone. First is hyponatremia. Second is hypoosmotic. Third one is euvolemia. The fellow is euvolemia. These are the important things. Now, endocrine deficiencies. Hypothyroidism, adrenal. What they will do? They reduce the cardiac output. Once the cardiac output is reduced, ADH is inappropriately stimulated, and that produces syndrome similar to isolated glucocorticoid deficiency, CRF mediated, corticotrophin factor mediated increase in the ADH. Treatment of the hormone disorder corrects the hyponatremia. Now, we started with hyponatremia, then excluded hypertonic hyponatremia, normotonic hyponatremia, came to hypotonic. Under the hypotonic, euvolemia we have taken up. Here we have set up a adrenal and thyroid disorder. Now, hypervolemic hyponatremia. That means the fellow has got hyponatremia, hypoosmolality, and hypervolemia. Differential diagnosis by urine sodium concentration. Urine sodium concentration more than 20, acute renal failure, chronic renal failure, urine sodium is less than 20, kidney is not at fault, congestive heart failure, nephrotic syndrome, cirrhosis. What are the fluid retaining conditions? Here, congestive heart failure, nephrotic syndrome, cirrhosis of liver, renal. Renal failure can be separated by looking at the urine sodium. Urine sodium is more, that is, kidney is not able to work properly, the urine sodium is getting wasted, so renal fault. If the urine sodium is less, that means there is hyponatremia in the system, there is excess fluid is there, and sodium is being conserved by the kidney because kidney is working well. That is why urine sodium is lower. When congestive heart failure, nephrotic syndrome, cirrhosis of liver. Movement of water from the vascular to the interstitial space. Activation of the neurohumoral compensation of the fluid retention. Okay. There is another condition called the exercise-induced hyponatremia. Supposing a hot summer, you go out and then you walk on the road, do a lot of marketing. Over 2 bags this day, 2 bags that way. Sun is on the top. You have worn very nice suit also in that summer, or a pattu saree. You have cooked it. Then what will happen? Sweating will be there, lot of sweating. Then you don't find any salted drink. It's water, plain water you buy from this one. Keep drinking. So not supplemented salt, only supplemented water, but dilutional pipe. In hot weather, when you go out, always carry a bottle of not water, but salted drink, a lemonade or buttermilk or something with salt. Or when you go buy something with the salt, not plain. When you're sitting in an AC room, it's okay. But when you are in hot weather, you lose water and salt. If you only replace water and don't replace the salt, the marathon runners, they will be running every 200 meters, there will be one fellow giving them the water. So if they give water, then they are out. They give salted drink, it is there. Mostly they give salted drink. Some local marathon runners, they keep on taking some salt. So water wherever they want. Okay, these fellows will be thirsty, let us give water. They give on every point he is picking up one glass and drinking. After 2 rounds, he will be down with hypo. This is called dilutional exercise induced. And women also very crazy. They also want to run along with men because equality race. In the equality race, women are having less water already because the problem is much worse. Okay, excessive drinking of hypotonic solution or more than 1.5 liters per hour of water are hypotonic sport drinks. If you take 1.5 liters per hour of water, which should be taken in the whole day, 1.5 to 2 liters. In 1 hour, you have taken 1.5 liters. What will happen? Body is dead. Or inappropriate secretion of ADH due to muscle-derived interleukin 6. When marathon runners, they run, muscle produce inflammatory kines. And that kine is a interleukin 6. This is known to work like ADH. So it doesn't allow the water to remain. So water goes in the air. It will have a lot. Okay. Now I have come to the crux. The hypovolemic hyponatremia. This is the most important one, or true hypo. So the patient comes with hyponatremia, no treatment unless you know where. Don't go on giving 3% sodium chloride and central pontine myelinosis. You produce all neurologically invalid fellows. We will bring. First of all, what I should know, I told you. What is the first step? Patient came with a report. His serum sodium is 128 or 125. What is the first step? Look at the osmolality. Osmolality is normal, high, low. If it is normal or high, I have to look for 4 conditions. Normal means
hyperprotein,
triglyceride. And this side, high means
glycemia and
mannitol, radio contrast. Radio injective contrast injection. These are the things excluded. So he is not a hypertonic, he is not normotonic, hypotonic, and hypo. Oh, he's a good fellow. We want that fellow. Then what is his volume? How do I know? Examine carefully. JVP, pulse, eyes, skin, pulse, BP, all. If the volume is normal and hypotonic and hypovolemic, hypotonic, normal volume, hyponatremia. That fellow, 3 conditions. SIADH, adrenal insufficiency, thyroid. Thyroid function you look at. Immediately 1 hour you know the report, normal. Adrenal function, little difficult to evaluate. Nonetheless, you evaluate that fellow also. CR also you keep. This is in say CR, the urinary sodium concentration is usually more than 20 million. Okay. The fellow is hypervolemic and hyponatremia, hypotonic. Hyponatremia, hypotonic, hypervolemic. That means somebody is retaining the fluid. That is why the hypotonicity and hyponatremia. Who is retaining? There are only four fellows who retain fluid. One is heart failure, liver, the kidney. Kidney is one thing. Heart failure, liver, and one more is there. Four conditions. So the kidney fellow will excrete more sodium in the urine because kidney is not functioning well. That's why more natriuresis is there. Serum sodium is more than 20. In all other fellows, there is reflux aldosteronism. That is, there is the kidney tries to conserve because of cirrhosis of liver, because of congestive heart failure, because of anemia, hypoproteinemia, wherever the fluid retention is occurring, other than renal cause, there is a reflux secondary aldosterone. We have seen they are the causes of secondary aldosterone. They will try to absorb the salt. So much so urine sodium is low. That group is segregated. Now we are left with fellows who have hypovolemic, hypotonic, hyponatremia. Hyponatremia, low sodium. Hypotonic, low plasma osmolality, less than 280. Hypovolemic by clinical exam. Ready pulse, fall of blood pressure, sunken eyebrows, sunken eyelids, and the eyes. Skin is very dry. Skin turgor is lost. You can pinch it for 1 kilometer. The skin like this. And leave it, it is still there because there is no. What is the commonest cause of that? Loss of fluid and electrolytes. Diarrhea. Gastrointestinal or third space sequestration. What is third space sequestration? What is third space? What are the first two spaces? Then the third space will come. If you know what is first space, know what is the second space, then you know what is the third space. First space is easier. Second space is ICL. And the third space is not blood vessel. Third space is peritoneal cavity, pleural cavity. Third space sequestration. That means fluid is locked up, just as we are locked up in this room. Fluid is locked up in some place, and the body's mechanism has no access to that fluid and sodium. That is why there is hypovolemia and that fluid has gone there in the peritoneum and sitting. And sodium also went along with that, because sodium and water are very close friends. Boyfriend, girlfriend. Boyfriend is going, girlfriend also. Boyfriend is water, so girlfriend is water. They won't be there inseparable. Sodium and water together will go wherever they go. They will there. So now what happened? These fellows are going and playing cricket in the abdomen. The sodium fellow and potassium. They are not available for function in the blood. That's the okay. Gastrointestinal third space sequestration are the causes for hypovolemia, hyponatremia. Water is lost all right, but sodium is lost more. That is why it is hyponatremia. Water loss is there, sodium loss also is there. Sodium loss outshines the water loss. So net hyponatremia also is seen. Commonest cause is vomiting and diarrhea. Commonest cause, particularly in children or even younger adults also, vomiting and diarrhea. Burns. Burns, the fluid is not through the kidney or vomiting. The skin is excreting the fluid. Because there is, all of us are happy because of the skin. The skin is not there, that's it. Entire plasma will evaporate into the hot sun. Okay, burns. Peritonitis, that is the third space sequestration. Because of the inflammation, the fluid went and is sitting and playing a game with those fellows. Peritonitis organisms, lot of work is going on, battle is going on, water has collected, peritonitis. Bowel lumen ileus, that means there is an obstruction to the terminal bowel and the water is coming and the whole bowel is bloated like another cavity. The bowel. There is an ileus Because of the aqueous fluid is not flowing, water is retained, and then more water is poured, hoping that the obstruction will be overcome. Obstruction is firm, so the bowel will heal. So what are the four causes now we have seen? Vomiting or diarrhea, very common. Burns, peritonitis, bowel illness. Now, loss of water and sodium, loss of water, sodium and chloride. This is called free water or hypotonic fluid intake. That means they are just like the marathon runners and all, they take excess water or hypotonic fluid intake. And vasopressin is due to volume contraction. The vasopressin is released because of the volume hypovolemia is there. Hypovolemia stimulates the vasopressin and there will be a hypovolemic hypo. Okay. There is a condition called osmotic diuresis. That means excretion of osmotically active, non-reabsorbable or poorly reabsorbable substances like glucose. Glucose is a very strong osmotic active substance. That is why the polyuria, the fellow is going for more number of times to washroom because the glucose is going through the filter. Okay, excess glucose is there, that is filtered along with the glucose water also because of the osmotic diuresis. And ketonuria like starvation ketosis, diabetic ketosis, alcoholic ketoacidosis, or sometimes bicarbonaturia, as in case of RTA, metabolic alkalosis, in which the associated bicarbonate leads to loss of sodium. There is bicarbonaturia and also sodium also is lost. So what are the common osmotic substances? Glucose is a very powerful osmotic substance. Ketone bodies are similar. Bicarbonate is also there. Bicarbonaturia occurs in renal tubular acidosis and metabolic alkalosis, in which the case the bicarbonate action leads to loss of sodium through the kidney. That is why the hyponatremia. There is one disorder called cerebral salt wasting syndrome. This can also be shock. Cerebral salt wasting. A rare cause of hypovolemic, hypotonic hyponatremia. Hyponatremia is there, hypovolemia is there, inappropriate natriuresis. When there is natriuria, hyponatremia, what should happen? Kidney should conserve and there should not be sodium in the urine. But still sodium is excreted. There is a deficiency at home and still you are wasting water. Means what? That means the kidney not able to conserve. When there is a deficiency, immediately we try to conserve. That is not God. Why? Because of intracranial subarachnoid hemorrhage, trauma, craniotomy, encephalitis, meningitis, where either infections, trauma, or subarachnoid hemorrhage. Release of V-natriuretic peptide in cerebral dysfunction. Differential diagnosis is SIAD. Cerebral salt wasting syndrome and SIAD are similar. What is the dissimilarity? Here, this fellow is hypovolemic, hyponatremia, hypotonic. The other fellow is euvolemic, hypo. That is the catch. Salt losing nephropathy. So sodium intake is decreased due to impaired renal tubular function, reflux nephropathy, interstitial nephropathies, heavy metal poisoning, post-obstructive uropathy, medullary cystic disease, recovery phase of acute tubular necrosis. Or somebody is pushing excess diuretics like thiazide diuretics, loop diuretics. So that blends the countercurrent multiplier, countercurrent exchange mechanisms. Water diuresis is in excess of the natriuresis. No. Conditions with urine sodium less than 20 means what? Urine is not appearing means kidney is able to conserve the sodium. When the kidney is not able to conserve, urine sodium will be more. Now urine sodium is less, that means kidney is able to take some protective measure for the hyponatremia. That means the cause is not kidney failure, extra renal cause. Non-renal causes of hyponatremia like gastrointestinal loss of vomiting, diarrhea, tube drainage. So these are then indwelling tube and then expecting the fluid to come out. All the pus and blood will come, the fluid also will be going. Third space loss of fluid, particularly example pancreatitis, burns, rapid increase in the plasma sodium concentration in response to intravenous normal saline. Saline induces water diuresis in the setting due to this. They're rare. Now, this is very important for you. So, patient of hyponatremia has come, less than 125 milliequivalents. Then I looked at the plasma osmolality. Plasma osmolality is elevated. Two conditions come to my mind. One is the paraproteinemia, the other is the hyperglycemia and count. Patient's plasma osmolality is normal, but hyponatremia is there. Hypertriglyceridemia, hyperprotein, paraproteinemia, like your multiple myeloma. Now, patient has come with hyponatremia, plasma osmolality is low. Yeah, this is true hyponatremia. What is the volume? Volume is high. Water retention conditions like cirrhosis of liver, nephrotic syndrome, or congestive heart failure. These are plasma volume status is normal, but the fellow has got hyponatremia and hypotonicity is there. Here, adrenal thyroid. Now we come to the last section, which is the hyponatremia, hypotonicity, hypovolemia. This is the classical. That's what we are looking at in this chapter. Assessment of volume status. Hypovolemia, volume also is lowered. That means body water is lost all right, but sodium loss is more than the body water. Immediate test will be, is it kidney or non-kidney? How do I know? Look at the urine sodium excretion. If the urine sodium is more, that means kidney is excreting sodium in spite of deficiency of sodium in the body. The situation is hyponatremia. What kidney is doing? It is throwing more sodium away. It is wasting. Father is very poor, son is very much expending. Like that. Father himself doesn't have much money to eat. This fellow is wasting in everywhere else. Then that means who is the culprit? The culprit is not father there. It is the fellow, the kidney. Renal loss, diuretic excess, mineralocorticoid deficiency, salt-losing nephropathy, bicarbonate due to renal tubular acidosis or metabolic alkalosis, ketonuria, glucose is the culprit, osmotic diuresis, cerebral salt. All of them come under. All that we have discussed. What is the picture? Hyponatremia, hypotonicity, hypovolemia, urine sodium is high. That means urine kidney is not able to handle the body situation, not able to adjust it, because either it itself is not doing well, like acute nephritis or nephrotic syndrome, or it's renal failure, or some diuresis is being forced, asking the kidney to throw the sodium. So diuretic excess. Or there is how does kidney conserve? Through mineralocorticoid only. That is not there. Then what it can conserve? There is no passport for the sodium to go inside. The passport is missing. That is mineralocorticoid. Or there is a substance which take, like bicarbonate, which takes sodium also along with that. When does bicarbonate occur? RTA, renal tubular, or metabolic. This is bicarbonate over here. Bicarbonate doesn't it always wants the sodium fellow because it wants the sodium form sodium bicarbonate. It drags the friend. I'm going to the bar. You also come on. Like I'm going to see the cricket match. You also. Friend also. Because sodium and bicarbonate, very strong bondage. So when there's bicarbonate here, sodium also is taken away. Or ketone bodies, like glucose, ketone bodies, these are osmotic substances. They also pull the water and sodium out. Osmotic diuresis, ketonuria, cerebral salt wasting syndromes, all have hyponatremia, hypotonicity, hypovolemia, higher urine sodium. See how easy to, if you know the subject, how quickly you can go and pinpoint what is the problem. Not infusing sodium chloride. Okay. Now, hypovolemia is there, but then urine sodium is less than 20. That means kidney is not at fault. Okay, kidney is trying to conserve. That's why there is no sodium in the urine. Extrarenal loss there, like burns, peritonitis, vomiting, diarrhea, third phase sequestration, pancreatitis, trauma. Extrarenal losses like common being vomiting, diarrhea, third space, burns, pancreatitis, and trauma. Third space includes many things like peritonitis, like your ascites, like your cirrhosis, like your pleural, this one, like your obstructed bowel with pouch and all those. So we have separated that. Now, euvolemia, there is no edema. Euvolemia should not have edema. Okay. Total body water is more. That's why fluid retention is there, but body sodium is more or less maintained. Look at the urine sodium. Urine sodium more than 20. That means there is excretion in the kidney. Glucocorticoid deficiency, hypothyroidism, stress, drugs, SIA. Okay. Because these euvolemic, we know euvolemic fellows are only these fellows. What are the fellows? SIADH, we have said. Hypoglucocorticoidism, hypothyroidism, stress and drugs they have added in the table. Now, hypervolemic, that means fellow has got edema, fellow has got body water is more than sodium. And then again you do urine sodium and then separate. Urine sodium more than 20, that means what? That is, sodium is not being conserved by the kidney. Kidney is not able to manage the sodium. Will acute or chronic pain. Kidney is able to do something, that is cirrhosis, cardiac failure, nephritis. Hypervolemia, three conditions are there other than kidney: nephrotic syndrome, cirrhosis, cardiac failure. Where the urine sodium is less than 20. Whereas if it is kidney is the cause of the edema, then the urine sodium is being wasted. So one flow chart is enough for you to differentiate hypovolemia, euvolemia, hypervolemia. Okay, so now, not over as yet. Hyponatremia is now I am giving you the flow chart. So serum sodium less than 135 milliequivalents. Symptoms are there. What are the symptoms? Confusion, ataxia, seizures, obtundation, coma, respiratory depression, all neurological signs. You should not mistake it for a neurological disorder. Hyponatremia is present as like a neurological, or patient may be asymptomatic or mild symptoms like headache, lethargy, dizziness, mild and severe symptoms. Symptoms like ataxia, confusion, seizures are there. It is severe hyponatremia. Mild symptoms are there. Then you go and look at the serum osmolality and do all this differential diagnosis. The fellow is having severe symptoms like seizures. Let me do corticotropin for you, and he will die. You have to put him to another flow chart. So you have to treat him in a faster way. So he set apart. If the symptoms are headache, lethargy, dizziness, and hyponatremia is presented, then I have time. I can evaluate, find out the cause. No, I'll treat you perfectly. I'm a perfect doctor. Our teacher also is a perfect man. Let me work out for 1 week. I will tell you the diagnosis after 1 week. Till the time you keep suffering with hyponatremia. You can't say for the severe symptom fellow. Mild fellow, it's okay. You can do the diagnosis. How do I do? Determine the serum osmolality. 3 possibilities are there: 280 to 285, normal osmolality, less than 280, low osmolality, more than 280, high osmolality. Done. If it is high osmolality, hypertonic hyponatremia, hyperglycemia is there. Check for mannitol, check for sorbitol, and look for radiocon. I told you, the radiocon, sorbitol, mannitol, one and the same. Sorbitol, mannitol, and then the hypertonic. These are the high osmotic substances. And radiocontrast. So you keep. When when you have hyponatremia with hyperosmolality of moderate or mild degree, not a severe fellow. The severe fellow, we have to treat him separate. Okay. The fellow has got hyponatremia, all right. It doesn't have very grave symptoms, mild symptoms, low serum osmolality, less than 280 is there, it is hypotonic hyponatremia. Then this is the fellow whom we have to work, assess the volume status. We'll keep that as it. We come to the left hand side. Normal osmolality, hyponatremia, mild symptoms, 280 to 285 milliosmoles, normal osmolality, isotonic hyponatremia, also called pseudo-hyponatremia, assessed for hyperproteinemia and hyperlipidemia. Very simple. There is a confusion. Now, I have got a fellow who has got hyponatremia, he has got hypotonicity, then I need to know the volume status. That means is it hypovolemic or normovolemic or you? Depending on that, I have to treat. Okay. Okay. Hypovolemic body, the volume is low, hypovolemic fellow on the left side, and the middle is the euvolemic, and here is the hypervolemic. Let us finish the hypervolemic first. That is increase of total body water. That means fluid is being retained by him. That is where dilutional hyponatremia is there. Then how do I know whether kidney or non-kidney? Look at the urine sodium. Urine sodium is less than 20. That means the kidney is doing a good job. So an extrarenal cause like heart failure, cirrhosis, nephrosis, hypoproteinemia, hypo. Okay, what is the treatment for that fellow? You throw the fluid away, give diuresis, and then fluid and sodium restriction. So the treatment is stop giving fluid. No IV fluids, first of all. Oral fluid also is restricted. Sodium also is restricted. And push the excess fluid out. When hyponatremia, hypotonicity, hyperolemia, edema is there, non-renal side. Now go to the other side. Same description, hyponatremia, hypotonicity, hyperolemia, renal cell. That means extrarenal causes like cirrhosis, heart failure, nephrosis, hypoproteinemia, all excluded. Now we go to the serum sodium is more than 20. That means kidney is excreting more sodium in spite of there being hyponatremia in the body. So renal failure. What do you do now? Here also fluid and sodium restriction and specific treatment for the renal condition and diuresis is the treatment. See, the hyponatremia treatment is not giving saline or hypertonic saline. See, look at that very clear. Now, come to the euvolemic fellow. Euvolemic fellow, increase the total body water, normal body sodium level. So, your urine sodium usually is more than 20. So, then what you have to do? You have to do the urine osmolality, and urine osmolality is more. That is, kidney is able to concentrate, and then you have syndrome of inappropriate hypothyroidism, adrenal drugs use, fluid restriction, again is the treatment. Urine osmolality is less than 100, that means kidney lost the concentrating ability, primary polydipsia, low solute intake, also called beer proteinemia, or also the marathon runners problem. Variable reset osmolality, fluid restriction. You see across all places, fluid restriction is the treatment. Except in cases where there is heart failure, you use diet. Across all the table, the main treatment for all those things is fluid restriction, not giving fluid. Okay. Hypovolemic fellow, this is the classical hyponatremia, hypotonicity, hypovolemia, then urine or non-urine, kidney or non-kidney. Again go to the urine sodium. Urine sodium more than 20, renal losses, diuretic, mineralocorticoid deficiency. Now give him isotonic saline. This fellow requires isotonic. Extrarenal losses like vomiting, diarrhea, third phase, bowel obstruction, isotonic, plus the specific treatment of the extrarenal condition. We will stop here.